Good evening, everybody.
Hi, good evening.
Hey, Dr. Mishra. Hey, Dr. Sathar.
Hi, good evening. Hello, good evening.
Hey, Vishwesh, how are you? Okay. Hey, Dr. Shukla. Okay. Hey, Akash, how are you? Okay. Prachi, can you mute Akash, Dr. Akash, and can you unmute Dr. Akash and the other panelists? Thank you.
Hey, can you hear me now?
Yes.
Okay.
Am I audible?
Yes.
Yeah, hi. Hi, everyone.
Hey, good to see you guys. Okay. It's 9 o'clock. Let's give a couple of minutes and then we can let people just trickle in, right? But no, thank you. Thank you all for spending time and joining us. Appreciate it. Yeah. Akash, do you want to try if you're able to share the screen and stuff, please?
Sure.
Thank you. Okay, fantastic. Yes. Okay. Okay, I'll be respectful for everybody's timing and stuff. So first of all, thank you so much for joining us today evening, India time, and morning US time here. I'm the founder of the SecOpp Second Opinion, but whatever the big name or whatever I say, but I can't exist without you guys help, because I'm just a facilitator of this thing. And our mission of not only providing second opinions to the patients in India, where you guys are doing fantastic job taking care of the patients there, but on top of that, how can we bridge the gap? How can we increase patients' trust in your care? And on top of that, like, you can have a friend in US or the other part of the world of, like, if you want to share the patient, if you want some connectivity and those things, and we can take care of it. I'm thankful to all of the panelists for joining, spending time away from your practice and family as well. I'm thankful, Mr. Vishwesh, for reaching out to your group of more than 1,000 oncologists and oncosurgeons all over India. And Dr. Akash, in a very short time span, he has been a distinguished professor at UAB, and he has an outstanding name in the lung oncology. Number of times people feel like, oh, he's so young and this, and no, don't go behind age, but the knowledge, the depth of the knowledge, the trials and everything, that experience he's bringing on the table, it's outstanding. I would just switch, I will just give the podium to Dr. Desai. Thanks so much for leading the show.
Well, thank you for the kind words, and yeah, really excited to be here and talk to a great panel, talk along with a great panel of oncologists here. And so I just have a few slides that I have prepared just to kind of keep the discussion sort of more structured, but please feel free to interrupt me at any point in time. So as was said, I'm Akash Desai. I'm assistant professor here at ONU Comprehensive Cancer Center. I'm also the associate director for our phase 1 and precision oncology program here at the Comprehensive Cancer Center. And I focus mostly on thoracic malignancies as my clinical practice, and really excited to be here. So I think I wanted to kind of, maybe just kickstart the conversation specifically about lung cancer, focusing on oncogene driven non-small cell lung cancer. And like I said, I have some slides that I want to discuss and a couple of cases as well. But I left more time for discussion, just, for any other questions or comments. So my talk is going to be structured as just initial slides discussing diagnosis and staging of non-small cell lung cancer, followed by specifically focusing on advanced or metastatic stage of disease and some case discussions. So talking about lung cancer subtypes, I think, as is common knowledge, lung cancer is, really differentiated into non-small cell lung cancer, which is the most common type of lung cancer in the world, along with the US and India, and then also small cell lung cancer, which is about 15% globally. Adenocarcinoma and squamous cell carcinoma are the two specific types that we focus on specifically, which are non-small cell lung cancer, of which adenocarcinoma is the most common and most prevalent globally. These are obviously sort of histological subtypes. So this is based on, sort of immunohistochemistry and pathology markers, which I have listed there. But essentially, the discussion today is going to focus on non-small cell lung cancer, which is essentially your adenocarcinoma and squamous cell carcinoma. So this is a slide, discussing what the NCCN guidelines has in terms of workup and staging. So when we talk about non-small cell lung cancer, obviously we have a pathology review. We have a patient sort of history and physical examination with performance status, any other symptoms. The pathology review helps us determine whether it's small cell or non-small cell. The physical exam helps us determine what the Eastern Cooperative Group performance status score is, essentially the physical activity or the physical health of the patient. And then obviously we utilize imaging, either CT, chest, abdomen, pelvis, or PET CT scan, which is generally preferred in our practice here for appropriate staging, as well as, certain lab parameters to understand what kind of treatments patients can actually receive. And then obviously molecular testing, which is a huge part of workup and staging as it stands in 2025. For early stage, bronchoscopy for nodal evaluation is very important. We're going to focus our discussion more on the advanced metastatic non-small cell lung cancer. So in terms of mutational testing, so currently, at least the International Association for the Study of Lung Cancer guidelines advocate for concurrent testing. So testing both through tissue biopsy as well as liquid biopsy or circulating tumor DNA, as it's commonly known. And the reason is that, obviously tissue can be insufficient, scant in certain specimens. And so in those cases, liquid biopsy is a great adjunct and complementary in terms of identifying any molecularly driven non-small cell lung cancer subtypes. But tissue is still the gold standard because it's the only way we can also determine PD-L1 testing. We will talk a little bit about PD-L1, which is an immunohistochemistry test. And then, the advantage of tissue biopsy is that when we do have that, you could not only just do IHC, but also run a whole genome or whole exome sequencing through the tissue. The disadvantage, obviously, it needs, it's an interventional procedure. It also takes usually longer to come back in terms of the testing results. While the liquid biopsy is obviously very simple, you just get blood from the patient and the circulating free tumor DNA is actually being tested. And that usually has a shorter turnaround time. However, the RNA fusion, sort of testing is more accurate in tissue biopsy. So again, both have this pros and cons. And so that's the reason why our practice generally is complementary testing. So more information, the better for us to make decisions for our patients. So some discussion on PD-L1 testing. So PD-L1, as I mentioned, is an immunohistochemistry test, which is usually done on the slides from the pathology biopsy, tissue biopsy that we have. And what we are really looking at is the actual receptor on the tumor cell and the expression of that receptor, which is the PD-L1. And as we are familiar with now, with the advent of immunotherapy, what these immune checkpoint inhibitors do is actually block this interaction of PD-1 and PD-L1, which is between the T cell and the tumor cell, which sort of provides a don't eat me signal to the T cell and decreases anti-tumor immunity. And so the way immunotherapy works is inhibiting this or blocking this signal so that the T cell can recognize the tumor cell. So when we talk about PD-L1 testing, it gets very confusing because across different solid tumors, it is measured differently. So there is tumor proportion score, which is the TPS, which is what we use in lung cancer. But then there is combined positive score, which is the CPS, which is used in gastric cancers and esophageal cancers and other tumor types. So in lung cancer, we use, as I said, the tumor proportion score. So what it is doing is essentially, counting the number of PD-L1 positive tumor cells, and then the denominator is essentially total number of viable tumor cells. So we are only worried about the tumor cell compartment. We're not really taking into account the immune cell compartment here. So as you can see, the tumor proportion score is a percentage score of PD-L1 positive tumor cells divided by the total number of tumor cells, both PD-L1 positive and negative. And based on that, the scoring is either sort of categorized into three buckets: less than 1%, 1 to 49%, and more than 50%. And that is relevant as we will talk on how do we use immunotherapy, do we combine it with chemotherapy or not in those sort of decision-making aspects from a clinical standpoint. So this is how we treat non-small cell lung cancer, advanced stage 4 today. And this slide is obviously very busy. It's not meant to sort of be read line by line, but I just wanted to kind of give a conceptual understanding on how we think about this. So essentially, there are two buckets of treatments. On your right is this bucket of patients who have oncogene-driven non-small cell lung cancer, may have any of these mutations for which we do have treatments that specifically target the genetic alteration of the cancer. And on the left is those patients who we are not able to find any of these mutations for the cancer. So in those patients, usually the treatment is chemotherapy along with immunotherapy. And what do you use depends on the level of PD-L1. As I just mentioned, PD-L1 more than 50%, you can use immunotherapy alone. You can use combination of immunotherapy with chemotherapy. And in the usually less than 50% bucket, we will use immunotherapy and chemotherapy combination, not use immunotherapy by itself per se. Although it is approved, the outcomes are better by combining chemotherapy. And then there are certain populations where I personally prefer using dual agent immunotherapy with chemotherapy, which is the PD-L1 less than 1%. So again, there's a whole host of different options, approvals by the FDA that have occurred in this space. And so they are all listed here, but essentially thinking broad-based about two different buckets for treatment. And we're going to focus more on the sort of oncogene-driven non-small cell lung cancer. So this bucket of treatment landscape for stage 4. In second line, which is typically after patients progress on the first line treatment, we have different options. Most commonly until now used were docetaxel or ramucirumab with docetaxel. So the origins have been sort of these chemotherapies, but now we have two approvals for antibody drug conjugates. So these antibody drug conjugates essentially are antibodies which are linked with a sort of chemotherapy moiety, which is known as the payload. And so two of them are approved currently, both based on IHC testing for HER2 as well as CMET. This is both accelerated approval based on single arm studies. We don't have any head-to-head comparisons, although those trials are currently ongoing. But these are also increasingly common options that we now have in our armamentarium for treatment for lung cancer. So I wanted to kind of then focus our discussion, sort of ground our discussion in clinical cases. So I have two cases that I wanted to present. So the first case is a case of a patient. I have some dates here, essentially coming in on November 2023. Patient had a history of cough, saw his primary care provider, underwent a chest X-ray, which demonstrated some pulmonary nodules. So he underwent a dedicated CT scan of the chest as well as abdomen and pelvis. And you can see here, you can see the bilateral lung masses, most consistent with widespread pulmonary disease. There are also some mediastinal and hilar lymph nodes, which are obviously not very visible in this particular cut. But you could see that, sort of bilateral disease, multiple pulmonary nodules, making that stage 4. And so at the biopsy, the pathology showed TTF1 positive adenocarcinoma. The patient then underwent a PET CT scan. Again, you can see these multiple pulmonary nodules in bilateral lungs, no other PET avidity in the abdomen or pelvis, and the MRI brain did not show any intracranial disease as well. So here is where we sort of, as I discussed in the diagnosis and staging, so we did the PET scan, we did the MRI, we have a stage. Now what we want to know is what is the PDL1 and molecular testing results of the patient. So PDL1 was 0%. So again, this image is a representative image where you can see there's really no IHC uptake for PDL1 staining. So it was 0%. And then in terms of genetic alterations from the NGS testing, we saw that there was KRAS G12C mutation for the patient, which was pathogenic, as well as an FGFR3, which was uncertain. And so this on the left is actually from the tissue, and then on the right is actually the Guardant ctDNA or circulating tumor DNA liquid biopsy test. And here you can also see redemonstration of the KRAS G12C. It also identifies that there are certain FDA-approved therapies, which I will talk about. So again, the value of concurrent tissue and liquid biopsy testing, and the fact that you can confirm the true nature of the genetic alteration that's driving this patient's cancer. So based on this, the first-line therapy, we started him on carboplatin, pemetrexed, nivolumab, and ipilimumab. So this is the dual immunotherapy because, as I mentioned, for the PDL1 less than 1%, the 0% in this case, we usually, or I typically usually prefer a dual agent approach. So that's what the patient was started on. But unfortunately, as you can see at the first interval disease, response assessment scan, patient had disease progression. So you could see enlarging multiple pulmonary nodules and masses. There was also enlarging hilar lymph nodes. So clearly the immunotherapy as well as the chemotherapy was ineffective in this case. And so in terms of treatment options, so the first-line treatment for KRAS G12C mutated non-small cell lung cancer is still immunotherapy, chemotherapy based. The targeted drugs that are approved in this space, adagrasib and sotorasib, are actually approved in the second line, meaning they are approved after patients progress on the chemoimmunotherapy treatment. So that's essentially what we did with this patient. We gave him chemoimmunotherapy, tumor response evaluation showed progression, and so the subsequent therapeutic choices were adagrasib or sotorasib. So then, this is again just talking about what I just mentioned, the dual immunotherapy plus chemotherapy and why we started the patient on that. And so second line, we chose the patient to be started on adagrasib. So that's a 600 milligrams twice a day pill. And that's the beauty of how we treat lung cancer in 2025 is if you're able to identify any of these molecular drivers, you can treat patients with stage 4 lung cancer using a pill. And a lot of the times, I'm sure you face the same thing in clinic. Patients are very surprised and pleasantly so. So this patient started adagrasib 600 milligrams BID in March. And then as I have here, you can see, these are results for ALT and AST. And you could see that there's an elevation as soon as the patient starts in March. It goes up to, AST goes up to 120, ALT goes up to 250. So that's about 3 to 5 times upper limit of normal within our labs. And so that is per the clinical trial criteria for adverse events is grade 2 ALT, AST elevation. So this is a known side effect of the drug, that is hepatotoxicity. For the KRAS G12C inhibitors, this happens also with sotorasib and adagrasib, both of them. So based on this, what we did for the patient is essentially, this is per the FDA label guidance, grade 2 AST or ALT, you decrease the dose to the next dose level. So instead of the 600 milligrams BID, we interrupted the dose and then reduced the dose eventually to 400 milligrams BID in May. And in just here, you can see that, since doing that, the, LFTs have come down nicely. So we held the drug here, and then as soon as it sort of went to the grade 1 level, we restarted. There was a slight blip here, but then everything has since normalized. So the patient is and remains actually currently on 400 milligrams BID. And you could just see, this patient was started on Krazati or adagrasib in March of 2024. Patient is still on the pill. He's doing well. He's mowing his lawn. He's enjoying time with his family. And we are sitting in August 2025. So that's stage 4 lung cancer, second line treatment, about 1.5 years out of the first line treatment, and really almost 2 years out from his diagnosis, or a year and a half out from his diagnosis. So that's sort of what we did. And then the beauty of this is even, so once we started him on adagrasib, we obviously did interval scans. So patient was continued on 400 milligrams BID because we did an interval CT scan, showed there was, slightly smaller lesions. And then in December 2024, actually, you could see the PET scan showing marked interval decrease in size and activity in the pulmonary metastatic disease. This is the initial PET that I showed you, and look at this PET in December 2024. Really amazing response with this drug. So as I mentioned, there are 2 currently approved agents, and there are multiple agents in the pipeline: divarasib, olomorasib, glesirasib, some developed in China, some actually being developed globally. And these are all KRAS G12C inhibitors. The way they work is they basically bind to the inactive sort of KRAS and then lock it in that configuration and prevent sort of the cycling of KRAS and the activity of KRAS and downstream effects of KRAS, mutated KRAS G12C. This is just some data on adagrasib from the pivotal clinical trial published in New England Journal of Medicine. Showed about 112 patients were treated, overall response rate of 43%, median PFS of 6.5 months. Our patient obviously thankfully falls on this, area where they had near complete responses. So obviously this is not the norm, but a really good response in this particular patient. And this again is the trial actually that compared second line adagrasib versus the docetaxel, which is considered the global standard of care, and showed that the progression-free survival was improved with a hazard ratio of 0.58 and p-value, which was significant. Based on this, I just also had a slide here to discuss KRAS G12C inhibitors and hepatotoxicity, as I mentioned. So both with sotorasib and adagrasib, especially when you're using it in sequence after following immunotherapy in the first line, we do see that there is a higher incidence of grade 3 hepatitis. This is actually some data that we published during my time at Mayo from the patients that we had treated both with sotorasib as well as adagrasib, but this particular cohort is sotorasib. And here we have this retrospective analysis, which actually shows that, in the first 30 days since immunotherapy, the rate of hepatotoxicity is much higher than, particularly at 31 to 90 days, and out of more than 90 days, the hepatotoxicity rates decrease drastically. So, again, this is a known toxicity, so we anticipate that, historically and comparatively across trials, sotorasib is slightly more hepatotoxic than adagrasib. And so that's why my sort of default choice right now to use is adagrasib, because the hepatotoxicity is less prevalent. We did see that in our patients still. But again, sort of the data points that perhaps adagrasib is better in terms of tolerability from a liver function standpoint.
Akash, thank you. A couple of things. At a time, there were a couple of panelists were having difficulty of joining, So if you're okay, we have distinguished panel of the panelists from all over India, like number one, Dr. Gaurang Modi is a director of Oncovin Cancer Center in Ahmedabad, and is fantastic setup with all the group of oncologists. They're doing beautiful job there. We have Dr. Rohit Pai, and he's also in the medical oncology with the ICTC group. And please, I apologize if I'm not able to speak certain names properly or if I'm not giving the enough information about you, but he's also a phenomenal speaker and contributing to the literature and stuff. We have Dr. Rahul Mishra. He's a radiation oncologist in Rajkot. We have Dr. Ritesh Suthar. He is assistant professor at GCRI Ahmedabad. He's a HOD in the nuclear medicine and specifically in the radiology side. Dr. Srijan Shukla, he's a surgical oncology side, so he's there. And Dr. Emmanuel Paul, he is a outstanding contributor to the oncopathology world. Do you think, Dr. Desai, if we can also see what's the Indian perspective, this is something like our perspective.
Yeah, I was actually going to say, I think this is a great.
Thank you, I appreciate it.
The case discussion since we completed one case and see how what experience has been in India.
Thank you. I'm a car mechanic. I'm orthopedic surgeon. I'm car mechanic. You guys are the real doctors. Okay, so I'll let you guys do it and I'll stop.
So yeah, please feel free to chime in, on your experience and any questions or feedback on the case. And what I can probably do is maybe I should stop sharing so we can all see each other properly. So I'm curious to know, in terms of NGS testing that we do in India, I know there's multiple companies now that are doing genomic testing. What is the practice in your clinic, for specifically for lung cancer, but even other cancers in terms of testing for NGS? Do you guys do both tissue and liquid, or?
So overall, hi, I'm Dr. Rohit speaking. Overall, we are sending limited panels, tissue-based panels, because of cost constraints. But in an ideal world, we would be sending a broader panel as well as liquid-based testing complementary, like simultaneously, because I think there are pros and cons of both the tests. But usually, we are sending 10 or 12 G.
So I think, that makes a lot of sense. Sorry, I think I didn't hear. So the limited gene panel, how many genes does it have? Is it like you are covering at least their 10 or 15 that need to be covered?
So my name is Dr. Gaurang Modi. So I completely concur with Dr. Rohit Pai's answer. So in India, there are three kinds of tests. First is a limited panel NGS, we can say. Second is a full panel NGS. And third, that is a liquid biopsy. So usually in my practice, I usually do a full panel package. Full panel means almost more than 50 genes they can cover. Or a limited gene panel means they will cover 12 genes. So basically a targetable gene that can cover. And we don't do a liquid biopsy as a first line with solid blocks. But the data is very intriguing that you suggest that. But in our practice, that is in a KRAS mutation patient, second is that anti-RK fusion gene, BRAF mutation gene. So all are not that much common, or at least we can say 1 to 2% of the whole cases. So in our practice, we usually focuses on the targetable medicine like EGFR, ALK, ROS1, and MET mostly. And if EGFR is positive, then our line of therapy would be somewhat changing. As we all know that the FLORA2 data suggests that osimertinib plus chemo is the standard of care. But in our patient, we cannot give osimertinib to each and every patient. So we extrapolate the data and giving gefitinib, alutinib with PEMI plus carbo 4 cycle, and then put the patient on the PEMI plus gefitinib maintenance. So this is the standard of care for us in our Indian patient. And those patients who are driver mutation negative with PDL1, we can say less than 50%. So in those patients, we would like to add immunotherapy plus chemotherapy at front for at least 4 cycles, and then according to response, we can put him on a immunotherapy plus partial chemotherapy, and then if progression, then second line of chemotherapy. So at that time, on second line, third line, at that time the doing repeat biopsy, it is a little bit challenging for Indian patients, so they don't accept our request for doing a second biopsy. So at those period of time, we would like to do a liquid biopsy to check any clonal evolution, like any small cell transformation or any genetic mutation transformation, like in EGFR, whether that patient transform into T790M mutation or not. So this kind of testing, there is a standard of care. For stage 3 lung cancer, post CTRT, we usually appreciate the patient data and we push the patient regarding the Imfinzi as the data is great. Again, the same for the small cell CLM, post CTRT, localized staging, we do push the patient for Imfinzi because the Adriatic has a great data. For the advanced stage small cell cancer, we do have two options. Either we use Imfinzi or Tecentriq. It is like that. So it is a concise application of chemo-immuno in Indian setup.
No, thank you. I mean, I think that makes a lot of sense. And I totally agree with, like doing repeat liquid biopsy, especially actually we do that too, because even here the patients are not amenable to biopsy again at progression. So I think liquid biopsy, we often utilize it there. And I do understand, I think, upfront diagnostic because of the cost constraints. So, that's obviously a different healthcare setup. But no, thank you, Dr. Modi, for giving us sort of a preview into how you treat lung cancer, non-small cell lung cancer patients. Anyone else wants to chime in?
Hello, sir. I'm Dr. Ruhi. I'm a medical oncologist at Shashwat Hospitals in Rajkot. And actually, I had a question for you. How much importance do you give to companion testing in PDL1? Like, if it's DACO platform, then only do you use pembrolizumab, or any platform TPS score is positive or CPS is positive, and then you go ahead with immunotherapy?
Yeah, that's a great question. So there are obviously multiple platforms. I think the most widely used and validated is the 22C3, which is the DACO. And we have some companies that report all the three, and we've done some work on looking at what is the correlation, and the correlation is not great, unfortunately. But to your point, we use only TPS score, so we don't really use CPS score to make decisions for lung. But I think you have to work within the resource constraints. So if you have, I can imagine if you have like a TPS score from some other platform, there's potentially not a lot of value of adding DACO 22C3 if it adds cost. So I think, that would make sense that you could just go ahead and make a decision based on just using that. And my guess is, and again, you can correct me if I'm wrong, but I think most patients in the Indian setup would get chemotherapy, right? Because I mean, also immunotherapy, from last I heard, I think one infusion costs in the order of lakhs of rupees. And so that can be very limiting for a lot of patients.
That's true, sir. But there has been a shift such that patients are able to afford immunotherapy, and we are able to enroll patients in a lot of trials, and there are a lot of good PAP programs. So around 20 to 30% of patients are able to avail immunotherapy option in our setting.
That's awesome.
And what Gaurang sir said is absolutely.
Yeah, and I think Dr. Modi brought up a very interesting point about gefitinib, and I know that is some data that came out of Tata Memorial with the gefitinib plus chemotherapy by Dr. Prabhash and his group. And I think, obviously that was the first data with the TKI plus chemo combo showing improvement. So although we know that the blood-brain penetration is an issue with gefitinib, I think that also makes a lot of sense. Is that what you see in your practice as well, Dr. Kumar?
So as Dr. Modi mentioned, we do have financial constraints with osimertinib. So we do use gefitinib, although such patients are slightly less in number. And so right now we cannot generalize, and we have to wait for more data to come out. But we do use gefitinib successfully in EGFR positive patients. Based on LAURA trial, also post CTRT, we are using gefitinib in EGFR positive patients. So let's see how it works.
Yeah, no, that makes a lot of sense. So I guess, Dr. Mishra, I would love to hear from you on, we do send patients with oligometastases for radiation, SBRT, and things like that. What is it in your practice like, and how many, patients you see for stage 4 that you do radiate?
Yeah. So basically, I'll answer your question, and also I have one question for you as well. So basically, now with the improved technology and in radiation, I would like to point out that the government scheme that is there is pretty generous, if I may say so. So we are able to do SBRT of the patients which are referred. In fact, like at our own center, we have motion management technique. So we are able to, I recently treated 2 patients with solitary lung met, though they were not from lung cancer. One was from the penile cancer, and the other one had breast cancer in the past. But we are able to treat those patients very smoothly with SBRT. When required, we give single fractions, or most of the times they are a little large, so maybe we go for 5 fractions. And those regimens are very well tolerated by the patients. But we make sure that there is a proper tumor board discussion before we go ahead for SBRT. And there has to be either it's a solitary metastasis that is there, or it has responded pretty well to the chemotherapy, and this is the one side that's left, or the odd man out. My question to you was regarding SBRT for localized lung cancer. Like, I've practiced in UK as a consultant, and over there they are very, very, may I say, conservative regarding biopsies for lung biopsies. So they have their own score, and then they find out that if there is a very reasonably high suspicion for lung cancer, and let's say the patient is having poor pulmonary function test, and the score is well above the mark, and the patient is referred to you for SBRT, they find it all right that in selected cases you can go ahead with SBRT for a localized lung cancer without a biopsy. I wanted to know what's the practice there in America. Would you be on the same page, or is it that no biopsy, no treatment?
Yeah, so I would say, and again, I'll be talking on behalf of my radiation oncologist here, but I would say, like in most of our tumor boards, when we have this discussion, if there is FDG avidity on PET, and if biopsy either is difficult or the patient has multiple comorbidities or issues with PFT or like old, like 80 years or older or something like that, I think with a high degree of suspicion on the SUV based on the FDG PET, I have seen our radiation oncologists sort of go with they say like, okay, it's peripheral enough, simple SBRT, 5 sessions, I can do it. But I think in most cases, I mean, 90% of the cases, unless, I guess you push them and there's no other option, they would want a biopsy in most cases. And I think, again, I'm at a big center in the US. US also has so many patients treated in the community. And so in the community, they may not have, interventional pulmonology or interventional radiology. So I'm sure that probably the amount of patients who get SBRT for a suspicious nodule with a high SUV max on PET is probably going to be higher in the community if we kind of look at the national landscape of the US.
So basically, in selective cases, you would agree to it, where maybe a biopsy is detrimental to the life of the patient, if I may say.
Exactly. Yeah, absolutely.
Okay. Thanks a lot.
And I guess, I had a question for Dr. Shukla as well in terms of, but I see he's on camera. Do you have anything to discuss first or have a question?
This has been a great learning experience for me because all metastatic cases. So I think as the only surgeon on the panel, I was enjoying sitting this one out. But I think that I have a few questions that I wanted to discuss with you all. And probably I'll start with the last one that Dr. Mishra was talking about, because, we had one of very passionate debates between me and my radiation oncology colleague regarding the role of SBRT versus surgery in early lung cancer. And I was surprised to see that ASTRO actually has a guideline which says that if a patient is not amenable for biopsy, it's absolutely okay to give SBRT without any biopsy proof. And in fact, 75% of patients in the prospective, the only randomized control trial, which was underpowered, I forget the name, but 75% of the Netherlands trial did not include any biopsy. So I think if biopsy is not possible or is not amenable, or a patient is refusing, but it's high risk based on any of the risk scores of the PET, it's completely reasonable to go ahead with SBRT. I think that's what the guideline says. I think the surgical data that we have from CalGB would tell you that 40% of the times you are radiating a benign nodule, which appears probably high risk on PET, but if you followed them up, it might remain the same or might go away. That's just one part. What I wanted to discuss was in non-metastatic setting, how do we approach the other molecular targets that are now coming up? So let's say the present algorithm that we have is if it's stage 2 or 3, along with the biopsy, we are ordering for AL-cross, EGFR and PDL1, 4 things. And if any of the 3, EGFR, AL-cross, come positive, then we are not considering the patient for neoadjuvant chemoimmuno. However, if those 3 are negative, then we are discussing about neoadjuvant chemoimmuno in our MDTs. My question was, what do we do with the other newer molecular targets now? NTRK, you have KRAS that you showed us now. We have many others that you will tell us about. So which are all the targets that we have to rule out before considering a patient for neoadjuvant chemoimmuno? That is point A. And the second question was in your center today, what is the inclusion criteria for neoadjuvant chemoimmuno in practice, not in trials?
No, great. Both of them great questions. And I'll start with kudos to you being a surgeon thinking so much about molecular testing. Because I will tell you, even here, we always sort of the molecular testing is left to the medical oncologist. So, really great to hear that you're thinking so much about that. So, to answer your first question, I think it's a very valid question. And I think even more valid question in the Indian context, and I'd love to see what our medical oncologists have to say, because absolutely perfect that you send EGFR, AL-cross1 and PDL1. That's probably what most centers do. I will tell you, even the big centers like Even MD Anderson and MSK, I have friends there, and most people with early stage, they actually send these rapid tests, believe it or not, single gene or rapid tests, because they want to make sure they don't have any of these, you don't really care whether they are PD-L1 positive or not per se, because the data is, for all comers, but EGFR ALK. So I think you're exactly, doing what would be needed to think about starting neoadjuvant chemoimmunotherapy. On your question about what to do with other agents, I think that's a great question. Obviously, we don't have any trial level data, and we may not have, because these are very, very small subset of populations. The problem I have with extrapolating that data into, let's say, something like NTRK or KRAS or RET or BRAF is that none of the other TKIs do as much for the natural history of disease as much as the EGFR TKI like osimertinib or alectinib. If you look at the survival curves for the ALK TKI, it's like 5 years even in metastatic setting. KRAS, it's barely, like we saw, it's like 9 months PFS. The survival is probably less than a year. So, and it has a lot of toxicity too. So I just don't know if these drugs are as potent, or also on the other side, if the disease, which is KRAS mutated early stage lung cancer, as amenable to treatment with a TKI in the early stage and would be as beneficial as the EGFR and ALK is. So that's why I think that remains to be seen before I implement it in my practice. Also, all of these studies have a random duration of treatment, like you have 2 years with ALK and 3 years with EGFR. So if I were to start a patient with KRAS on KRAS G12C, I don't really know how long should I keep them on it. And if the answer is that KRAS is a more aggressive disease and I keep them indefinitely, I don't know if that's the right answer. With regards to your other question on how we manage stage 2 and 3 patients, I think this data is evolving. And at least from what I'm hearing, so across the US, the patterns are very different. At my institution, currently the surgical preference still is to do surgery first for stage 2s, unless if it is stage 3 patient, maybe a larger mass, or having obviously single station N2 disease. I think multi-station N2, I would still probably do chemoradiation. Again, that is a subject of discussion. But because I've heard centers in New York say, like, we basically give neoadjuvant to all patients, stage 2 or stage 3. The argument from our surgeons here locally is that if you look at the data from all those studies, the maximum benefit is for stage 3, and I agree with that. So if you had a patient where you could take them to surgery, like, next week, fit patient, good PFTs, less comorbidities, then why wait? And that's the argument our surgeons make. So there are some trials that are being run through the cooperative group on answering those questions, but currently practice for our institution is stage 2 usually end up going surgery first, and then adjuvant chemoimmunotherapy or adjuvant osimertinib, alectinib, depending on molecular results. And then if stage 3, then usually they go neoadjuvant chemoimmunotherapy. And then I guess the other question now also is, do you do perioperative? So do you do adjuvant immunotherapy after neoadjuvant, or you just skip it? I think my practice is based on pathological complete response. If I have that, I sort of gear towards omitting any more adjuvant treatment, because Checkmate 816 did have overall survival benefits. So did Keynote 671. So there is no one to say that one or the other answer is right again in this case. So that, but I will discuss with my patient, and I'll usually say, well, if you have a pathological complete response, the chances of your cancer coming back are low. Do you want to come in every 3 weeks, get an infusion for the next year, or do you want to just come in every 3 months, get a scan, and treat you if there is a recurrence?
That's great answers. I think at our center we are still at anything that's more than 4 centimeter primary and anything that's N plus. So it doesn't matter whether it's N1, N2A, or N2B. Ultimately, I think it's the response to treatment that prognosticates a patient better, I feel, than the individual stage. The 2 things that I was thinking when you were presenting the first case was, is there any role of liquid biopsy in non-metastatic setting? That's A. And two was, we were talking about oligometastatic, but is there any role for local therapy, surgery or radiation in oligo recurrence or oligo progression? Especially when we're talking about gathering biopsy, we've had problems where we were not able to get biopsy. So we essentially ended up doing sublobar resections so that we can get the tissue across to our medical oncology colleagues so that they can do the retesting and then proceed.
Yeah, so I mean, I guess I'll answer about the oligo recurrence. So for oligo recurrence, I would say that there is a lot of role for radiation. I mean, our surgeons typically, when there is a stage 4 patient with a recurrence, or it's difficult for me to convince them that you do a wedge resection or do surgical approach there. But yes, I utilize SBRT or radiation oncology referral very, very commonly. Be it a singular met in the liver that has come up, or local recurrence which potentially wasn't in the previous radiation treatment field. So I utilize it a lot. I'll answer your first question about liquid biopsy in early stage. So the only reason I use it, I mean, obviously, the payment systems are different and I don't have to worry about coverage. But if I had to, then I probably don't think there is a lot of role for liquid biopsy in the early stage setting, especially if you're getting good tissue testing. The emerging role is actually utilizing sort of the level of ctDNA that is present. Is it positive or negative to potentially, I wouldn't say predict outcomes just yet, but inform treatment decisions. I mean, what I mean by that, if you have a PATH-CR patient who has a positive ctDNA, maybe 8 weeks late after surgery, potentially would benefit. Again, this is all a gray area at this point. And also, most of our liquid biopsy tests aren't really that sensitive yet for early stage. Some of the studies that, all the Checkmate and all those studies included ctDNA testing, but those were all sort of minimal residual testing rather than the traditional liquid biopsy that you send as a complementary diagnostic. So you have to pick and choose the test also. So for example, when I send for stage 4, if I'm thinking about like Guardant, which is one of the companies that we use, I'm mostly sending Guardant CDX or 360. But when I'm sending in early stage, the test is totally different. It's called Guardant Response or Guardant Reveal. So those are minimal residual tests. Those are the ones which can be useful. But again, I think, how do you use them is still evolving. And I know Dr. Mishra has had his hand up. So please, Dr. Mishra.
Sorry for disturbing again, but just one last question. It was more like a comment as well. With a big armory that you have of TKIs, EGFR and everything, I mean, this is something that I am totally against, but would you advocate for locally advanced lung cancer with mutation positive EGFR to just give some TKI without even considering local treatment? Because I'll not say this, but some places, rare scenarios, I've seen the medoncs being so confident with the TKIs that, is radiation not being considered in those settings? Is there a strong enough evidence to do that?
That's an excellent question, because I can see running into a situation. I haven't run into a situation like that, but I can see running into a situation where the argument is, if you are going to do TKI for indefinite time after chemoradiation anyways, can I just avoid radiation and chemo and just go on a TKI? A patient hasn't asked me that yet, but I think that is, I wouldn't think that would be unreasonable in a specific patient scenario, comorbidity, risk of chemotherapy, radiation. But I think traditionally, if the disease, because I think, so I would think about it that you are essentially changing the goal of treatment if you are doing that. Because the goal of treatment for us doing chemoradiation and then TKI, we still say it is a curative intent.
Exactly.
But when you just put a patient without chemoradiation on TKI, I think you're sort of more steering towards palliative, because I don't really know without radiation, local radiation and chemosensitization, that you can actually claim that you're trying to cure the disease. Because all the TKIs are, sort of more sort of cytostatic, if you will. They're not cytotoxic therapies per se.
But I think interject if we look at LAURA, it was 39 months versus 6 months. So with CTRT, so 6 months, for 6 months, are you subjecting the patient to radiation, chemotherapy, all that? And then, it was not very, like the PFS was, there was a stark difference. So I think this is something which we need to look at, whether we look at the ctDNA clearance or something like that, rather than put the patient indefinitely on osimertinib. That is something which we need to look at. But I think this is a valid question, especially in stage 3.
Yeah, and I think you bring up a very valid point that the control arm in the LAURA study, as you pointed out, the patients with chemoradiation did not do well. So obviously, clearly, it's not enough. But I guess whether we can avoid it completely is a different question. But you're absolutely right. It
is not fitting in our psyche that we can avoid it completely, avoid radiation or chemoradiation is unresectable. That is not that is not the way we are taught. But I think we need to evolve our thinking also with the evidence which is coming up.
Absolutely.
Maybe patient selection is the key.
All right, I think we are getting really up to the hour mark here, but really grateful for all your inputs and discussion. Any last minute thoughts, questions? So in those last few minutes, maybe I just wanted to, Dr. Pai, do you have any comments?
There was another comment that how do we choose patients for chemoimmunotherapy? Depend on what sort of targeted therapies do we, or what sort of targets do we actually see? So practically speaking, in localized disease patients we are considering for chemoimmunotherapy, also we are doing the same limited stage. Probably there are certain targets which are immunogenic, like BRAF. Maybe something like MET. Feel that immunotherapy probably would be overkill, and I think that maybe we can avoid that because I don't think that immunotherapy we have that much data. For example, even for ROS1, etc. Because classically EGFR ALK is always eliminated when you are talking about immunotherapy trial, but for ROS1 even for example, probably immunotherapy won't be doing that well. So I would hesitate. But if there is BRAF, for example, I won't hesitate to give chemoimmunotherapy. Definitely I would give it because they are seen in smokers, they are potentially immunogenic, they have reasonable tumor mutation burden, etc.
No, I think absolutely agree with your point. I think that, BRAF, you could definitely do chemoimmunotherapy. I mean, KRAS obviously is an example where, patients do really well with immunotherapy. So I think that brings to the point of discussion with Dr. Shukla's question is that not all targets are equal, right? So that's the thing. I think depending on the target and how the natural history of disease is, it makes a lot of difference on what you use in the first line. I guess my question really was just out of curiosity, I'm sure, I guess I should have disclosed this earlier. So I'm from Ahmedabad. My parents and my in-laws still live in Ahmedabad, and I know the culture obviously is you obviously want to get 1 or 2 referrals before you start. I'm sure in an oncology setting that's probably the case. But just curious how are there patients really seeking opinions outside? And I think this may be a good closing question, Dr. Shah. And I'm sure you would like to hear more on how frequently do they hear from the patients that I would love to get an opinion, potentially an international opinion, stuff like that.
I guess there are different class of patients. There are some patients who probably cannot afford the treatment. They would only like to get the treatment in the government-sponsored schemes and things like that. Those class of patients probably they may do some soul searching now. I mean, they'll go to different places in that area or maximum nearby, but they'll not probably go for the international opinions and things like that because they probably cannot do that. There will be some elite class of patients or else relatives of people who are abroad or have some doctor in the family or some people like that. Yes, they may be happy to have that opinion if it is given in appropriate time and it is within their reach. Naturally, everybody would not like to fly to US, UK and then get that thing. But I must also point out that people in India now do have quite a lot of confidence in the local doctors as well. So they may take like 3-4 opinions, or they may jump cities. Like from Ahmedabad, they may go to, let's say, Bangalore or some other place, or Mumbai for that matter. But even that proportion is now coming down because locally bigger things are available and facilities are available. But yeah, nobody would mind if that facility is being offered without them having to leave their own place. And it is being given in a limited period of time, because when the moment cancer is diagnosed, the anxiety levels are pretty high. One of the things that comes to their mind is, let us get the treatment started as soon as possible. So time is really important in these cases.
So I have been in the shoes of patient or family, because my mom got diagnosed with glioblastoma in 2020 in the peak of the COVID. And I came to India, and I was lucky to be surrounded by smarter people like you guys are. You guys helped me a lot. So as all of the friends like Akash and other panelists or other physicians on the SecOpp, they are part of this group. They helped me a lot. And instead of 2 months, just for answering those questions, I was able to get 2 years of her life. So main reason to start was, number one, is to increase confidence of the patients in your care, because you guys do fantastic job, but they always feel like, the grass is greener on the other side. If they're coming for treatment in Rajkot, they feel like the doctor in Ahmedabad is superior. They're coming Ahmedabad, they say, well, Mumbai is superior. They come Mumbai, then feel Delhi is superior, right? So it's more of preventing them from stopping, from shopping around. That was a main thing. So, and second thing, number of times you have doubt, there are a number of things which is not published, So like having the leaders like Akash and other people, that could be very helpful. Like, that's what we do. And through this webinar series, that's what we want to do. I mean, we want you guys to tell us, hey, what you want. You want to Dr. Mishra or Dr. Pai or Dr. Modi, Dr. Ruhi, or all the physicians. I'm sorry if I've not mentioned name, but if you say, hey, no, I want to do this for the patient outreach program, can you provide a person, Or we want to do for the physician outreach, can we do that? Would love to do that part, That's one thing that we are doing through our NGO, and we are also introducing the free diet counseling to the patient, whether they become our patient or not, Then psychotherapy. It's more of something smaller, like an initiative we just want to add on this thing. And I'm flying out from here to India on Friday, and I'm planning to visit majority of you guys in person. I'll be in Rajkot, Mumbai, Ahmedabad. I'm going to meet all of you guys, as many people as possible. I know that my emotions are attached, but at the same time, it's more of like, I like to see what's real needed and how we can make a difference in the society together. Before I do the closing remarks, I would like to just give podium to Vishwesh. Vishwesh is a pharmaceutical, they help us to reach out to. We use their help, Vishwesh's help for reaching out to the more than 1,000 plus oncologists and oncosurgeons, and for like anybody whom we can reach out. And we will share this YouTube link and all the things for everybody, so that can be shared or used for the educational purpose. But I will just finish my remark. Thank you all, and thank you for your contribution. Vishwas, please.
Yes. Thank you so much to Dr. Akash for your insightful session on these cases. Also, I would like to thank everyone, all of the panelists, Dr. Gaurang, Dr. Rohit, Dr. Srijan, Dr. Rahul, Dr. Ritesh, as well as Dr. Emmanuel Paul. Thank you very much for your insightful session. And so basically, Zoetic, we are a pharmaceutical company. We are an up-and-coming unit based out of Ahmedabad, where we are setting up a facility, which is an EU GMP compliant facility, where we will manufacture different kinds of tablets, capsules, as well as injectable, both lyophilized as well as liquid formulations. And we are a 25-year-old company, and we have entered into this field of oncology, and we are happy to be associated with SecOpp. Thank you so much, Dr. Ashish, for this initiative of having this webinar and bringing interesting cases to the medical fraternity over here.
Okay. Now, thank you all. Have a good evening to everyone there in India, and thank you all of the panelists and viewers, and looking forward to have this webinars more frequently depending upon your needs and depending upon your suggestions. Thanks again.
Thank you, everybody. Thank you.
Thank you all.